Yeah, I'm just testing again to see if that's working. Well done, Sean. That's great.
Yes, yeah, I can hear now.
Hi, this is Alex. Can you hear me?
Hi, Alex. Yes, we can hear you. Thanks very much.
Great.
Hope you're well.
Thank you. Yes, I am.
Colleagues, just to say we'll begin in about 2 minutes. We're just doing some last minute tech bits, but we'll be with you very shortly. So feel free to chat amongst yourselves. Lovely. Well, I think we'll get started then. Thanks very much, everyone. Hope you had a good summer break. This is our first Health and Adult Social Services Standing Scrutiny panel of the civic year, because the last meeting fell on the date of the general election. So I think many of us were engaged in activities elsewhere. I'd particularly like to welcome new panel members that are joining, and our colleagues from the Council and NHS services as well. But I extend a warm welcome to our new Cabinet member, Councillor Newster. It's really good to have you with us this evening. And I'd also like to congratulate Neha on your appointment as the Director of the Borough-Based Partnership as well, and look forward to continuing to work with you. So thank you very much. The meeting this evening is being held in hybrid form, so some members and officers are joining the meeting online, and others of us are here in the room. We're also live streaming on YouTube. If I could just remind members and officers who are online to be on mute, just so that we don't get any feedback, and if you do want to ask questions, if you could use the raise the hand icon, that would be great. I think in terms of online panel member attendees, we just have Councillor Baines, who's attending online this evening. So if I move on to apologies for absence, we have apologies from Councillor Tai, who is being ably substituted by Councillor Mohammed. Thank you very much, Councillor Mohammed. And we have apologies from Carleen Duffy, one of our co-opted members from Health Watch Ealing. And David, you're very welcome again in Carleen's place, so thank you very much. There are no urgent matters this evening, so we move then on to declarations of interest. Can I ask if panel members have any personal or prejudicial interest in any of the matters on the agenda? Councillor Dan Crawford.
Yeah, thank you, Chair. I think I have to declare that item 9, is it, Meadow House? I donate. I am, in the terms of the report, I am an active donor to, I'm an active donor to the Meadow House Hospice in honour of our former colleagues, Councillors Paul Woodgate and Patricia Walker. Thank you.
Thank you, Councillor Crawford, and I appreciate the advance notice of the conflict, and we've discussed that whilst you're an active donor, that doesn't preclude you from asking questions in this evening's debate. Can I ask if there are any other active donors in relation to Meadow House? Councillor Kate Crawford, yeah. Oh, just use your microphone, thanks.
I am sort of an occasional donor to support fundraisers. Thank you.
Also fine, thank you very much. Any other conflicts of interest, Councillor Conti?
Well, not conflict of interest, but the GP in North West London. I seem to declare at every meeting, so I thought I should continue to do the same.
And that's prompted me to make my regular declaration as well, as employed by the Nursing and Midwifery Council. Thank you. Anybody else? I think we can move forward. So items to be considered in private. There are no matters as far as I am aware. So that we move on to item 5, which is the draft panel terms of reference and the work programme. Can I check with panel members if you agree with the terms of reference which were provided? So they just simply outline the membership and the general functions and specific powers of the panel. Councillor Kate Crawford.
Right. I'm curious to know 2.3 with regard to the lead members mentioned here. We had lead members last year, did we? And who were they and what were they leading on?
I will bring Anna Marie in for that.
Councillor Crawford, each year we ask for lead members, and we didn't have any appointed last year, but that doesn't stop it from happening this year, if that's what the chair wishes to do.
May I suggest that in future the whip, you ask the whip who are the champions in mental health. I've been the carers champion, so maybe I was away or whatever. But I certainly would put myself down as the lead member for carers.
Lovely.
That's everything, actually, as far as I can see here.
I think I'm also the champion for dementia. So I think there's a few of us that have got those roles. But what I'll do is take away your suggestion of liaising with the whip, so that we can just make sure that those are reflected in future years. Any other comments on the terms of reference? Have I got agreement from the panel? Agreed. Thank you. So in terms of the appointment of co-optee members, we have 3 co-optee members that we are proposing to reappoint this evening. So we have Anthony Brooks on behalf of the Ealing and Hounslow voluntary service, who's been on the panel during the previous year. And Anthony, I know you've said that you're willing to give a commitment for a further year, which is excellent. Alan Cook, who is a member of Ealing Health Watch. You're very active and have been a long-standing co-optee member of the panel representing patients and the public in health and social care services. And I think you're also a trustee member of the Ealing Centre for Independent Living as well. So, and you have also given a commitment to stand again this year. And then whilst David is representing Carleen from Health Watch Ealing, Health Watch have put forward Carleen as the co-optee for the panel again this year, a really important role in terms of providing insight into the experiences of people interacting with health and social care services locally, and presenting that patient voice in the work that we do. Are we happy to reappoint all of those co-optees? Do I have agreement? Thank you very much. And then in terms of the final appendix, which is the panel's draft work programme, so we are looking to make some, well, we are making some amendments to the work programme. So the item on maternity services, which was scheduled for November, will move to March, because it's highly likely that in the November meeting we will have the CQC report to look into in terms of our CQC inspection of adult social services. And we've also scheduled in some reports on cancer screening and immunisations and vaccines in the May meeting. You will see there is still some gaps in the work programme. That is very deliberate in order to allow us to pick up items throughout the course of the year, but very happy to take any comments, suggestions, contributions from panel members. We always have, I think, a list far more ambitious than we're able to get through during the course of the year, but any suggestions would be very welcome, and we can, if we can't get to them this year, we can add them for future years and future consideration as well. Any suggestions from colleagues or comments on the work programme at this stage? Councillor Crawford.
So, Chair, it's just to say that we can obviously do some visits as well, and I know you've been keen to do that in the past, but maybe we could think about some places that we haven't got to or would like to get to. Although I'm giving you more work now, Chair, sorry about that.
Well, no, actually, it's very fortuitous that you mentioned that, because just this afternoon, myself and Anna Marie were talking about visits, and I think there'll be a request coming Mr. Titcombe's way for us to look at the Community Diagnostic Centre, but I think there's also scope probably to do something with our November agenda. So more to follow on that, but very keen to get out and about to services. So thank you for raising that. Do I have agreement on the draft work programme? Thank you, colleagues. So I then move on to the minutes of the previous meeting. I am just looking for confirmation that we are happy, for those of us that were there at the meeting in May, that they're a true and accurate record. Is that agreed? Thank you very much. Which brings us to item 7 of the agenda, which is a verbal update following the CQC inspection of adult social care. And Kerry, I think you're going to share some reflections, and Councillor Newstab, you're also here in your capacity as Cabinet member, so you can have some time, of course, as well to share any thoughts that you have. So Kerry, over to you.
Thank you, Chair. Just to remind colleagues that the CQC inspection framework is a new piece of legislation that gave the Care Quality Commission the powers to inspect local government social services departments within adult social care. The framework was piloted in 2023 and then rolled out in a formal manner towards the end of 2024. North West London was one of the first sub-regions to be included within the inspection framework. So CQC have been focusing on the local authorities in North West London. The cycle has gone Hounslow, Harrow, Brent, Ealing, Kensington and Chelsea, Hillingdon, and I think Hammersmith and Fulham are still waiting confirmation of the dates when their inspections will begin. The inspection process is obviously something that's under development and that the CQC have been working through. We received our notification in January that we would be expected in the coming months. We then had the inspectors arrived with us towards the end of July, where there was 3.5 days of intense activity for council staff, and very much appreciate the engagement from partners. And I know many partners around this table were interviewed and spoke to the CQC inspectors. The timescales, and as you mentioned, Chair, hopefully we'll have the finalised report for the November meeting, is that we're expecting a draft report to come to the council in the middle of September. We then receive 10 days to fact check the information that CQC have gathered and their commentary about the council services and our partnership work, and then a final report to be available hopefully in the middle of October. But I wouldn't bet your house on it in terms of the timescales, because things are moving and there's a lot of challenge within the CQC organisation as a whole that you may have seen within the press. Feedback in terms of the CQC experience, so across North West London and London as a whole, has been challenging. I think there's a lot of consideration and discussion at a London Council's level and also a London ADAS level about how the National Inspectorate body understood London as a specific economy within the national picture, and I think that's something that will be discussed further. The outcomes for the inspections that we've seen in North West London so far is that Hounslow received a good rating, and it's now publicly available that Brent and Harrow both requires improvement in terms of the inspection programme. People ask me once a day, twice a day, sometimes 3 times a day, what we think the outcome is going to be in terms of the CQC inspection for Ealing, and honestly, I don't have a clue at this stage. I think my colleagues put in a huge amount of work, partners put in a huge amount of work. It's distracted us from doing our day-to-day jobs. We've spent additional resource in preparation for the inspection, and it's taken a lot of time and energy when we're doing complex and challenging tasks for the communities we serve in Ealing. All I can say is that colleagues that I've spoken to from the council and within the partnership came away from the inspection process energised, vibrant. The feedback that I have had from CQC said the partnership and the staff working for Ealing Council were hugely passionate and hugely eloquent. I almost said elegant. Elegant as well. Eloquent and capable. And I think whatever the outcome is, that's what I'm looking for as the statutory desk in terms of my colleagues being engaged with the process and feeling proud about how they've presented the services we provide to the communities in Ealing. But we shall see when the report arrives. So apologies that it's only a verbal report at this stage, but as soon as we get the more formal confirmations of the position, it will be obviously shared within the committee, and hopefully that will be in time for the November committee chair. Thank you.
Brilliant, thanks, Kerry. Councillor Newstab, I'll come to you for a reflection on your experiences.
Yeah, I mean, from my perspective, firstly, thank you for having me here, Chair, and it's great to be in this role, and thank you to so many of the partners and officers who have supported me with getting up to speed. A very strange time to join, as we were imminently to be expected, but I was enormously impressed by the, as Kerry said, the energy, the passion, the focus, and the sort of excitement that the team had in order that they had an opportunity to reflect back those elements of their work that they were really proud about. Again, the slight disconnect with the inspectors' understanding of some of the London challenges and the specificity of the opportunities that diversity affords us, but the inequalities that we experience within our borough left something to be desired, I suppose. Obviously, you know, whatever the result is, it was an astonishing effort, and we're very proud of the partnership and the teams and everything we did. So fingers crossed. It's probably me that's asking you 3 or 4 times a day. But yeah, it's been quite an experience, and it is one of those things in that kind of regulatory framework to get beyond it has been great, and we can crack on with an awful lot of other projects that we've been holding on to. So fingers crossed.
Thanks very much. And as Kerry said, we will you know, hopefully have the draft report, or we'll have the report rather by the time of our next panel meeting. So we'll obviously be able to scrutinise the report and also the organisational response to that and inform that in future. But are there any kind of questions based on the information that either Kerry or Councillor Newstab have asked? I think it was a really helpful update, and thank you for providing it. Any questions? Yeah.
Can you hear me? Yeah. Well, is there an intended cycle for these to happen regularly in the future?
Thank you, Anthony. Thank you, Chair. So regularly, we're thinking every 4 to 5 years.
Right.
There's not an expectation for organisations that requires improvement to be inspected more regularly at this stage, but I think it's still a developmental process.
Thanks very much. Councillor Mohammed.
Just a question. When was the last time CQC visited Ealing, and what was the outcome? Thank you.
Thank you, Councillor Mohammed. CQC haven't carried out the inspection programme with local government before. There was a previous national body. I can't remember what the title was. It's something to do with, we think it was something to do with the Audit Commission. There was a framework. It was about 13, 14 years ago. My understanding is that Ealing was last rated as good, but under the separate framework that was carrying out the inspection process.
I think it's fair to, using my regulatory experience, I think it's fair to say also that the previous inspection framework was very different from, so I think comparing is quite difficult. Councillor Conti.
It was interesting because I think both you mentioned about the CQC didn't understand some of the context of London. I know Councillor Newstab, you touched on about the diversity element. I was wondering a bit more about what is it that they didn't sort of, what don't they appreciate or don't understand, which sort of other boroughs across London have found as well.
Councillor Newstab.
Yeah, I mean, I think it's probably I think the extent to which adult social care is such a large part of what we do as an authority, but there were some elements like the fact that we use not by choice, but we use a higher number of agency staff than might be the case in a more rural setting. And the reason for that is often that people will prefer the higher wages because it's very expensive to live here. So it's those sort of contextual understandings that felt quite jarred. And there were other elements that were really about the sort of complexity of the comorbidities and the intersectional elements of some of our residents that really meant that the needs that we meet are of significant levels. And there were just various other elements. I mean, to your point, Councillor Mohammed, the inspectors have been inspecting care homes and been inspecting other domiciliary care. That's kind of where they're sort of rooted. And now they've moved into inspecting an environment that's quite different. So there were some different things around not fully understanding the role of scrutiny versus portfolio holders versus health and wellbeing board, and the context of the health partnerships that just in some cases felt a little underdeveloped with the inspectors. But I'm sure they're in they're having teething issues themselves, and I'm sure we will be very keen to support them in expanding that knowledge.
Kerry, did you want to add to that?
Yeah, just to add as well that and Councillor Newstab's absolutely correct. The complexity of the NHS environment in West London, specifically in Ealing, in terms of the number of acute hospitals served for the population in Ealing, wasn't quite in people's understanding of how those complex relationships work here compared to other areas. The other aspect was the performance information. London boroughs perform very differently than national local authorities in terms of the off-log indicators, and there's a London bubble in terms of how performance compares within London, but not compared to national activity and performance that's not fully understood. I think, as Councillor Newstab says, this is a developmental phase still for CQC, and we are feeding back to them as an authority, but also from a London ADAS perspective and also London councils.
Colleagues, we will have, as I mentioned, more time at the November meeting. So I'm going to, unless there are sort of burning questions for Kerry or Councillor Newstab, I'm going to propose that we move on. Before I do, I just want to thank Kerry, you and your team for your engagement in the process, which I think's been exceptional. But in particular, please pass on my personal thanks to Jill Ford, who was sensational in preparing me for my interview. But I know many of us had sort of similar experiences as well. So be really grateful if you could do that. So we're moving on to item 8, which is about the care line. We've got about 40 minutes scheduled. I'm telling you up front, so if I go, we're moving on, then I've been clear in the expectations around timings. So we've got about 40 minutes scheduled to discuss the care line. I think this is a really good opportunity for the panel. Councillor Newstab's here and Kerry as well. It's the double act again to present the report. So you're providing an update on the care line activity following the closure of the Ealing service and the transfer to Harrow. Jess Murray, the Assistant Director for Housing and Environment, and Avtar Mann, the Head of Service for Integrated Commissioning, are also attending and will be able to pick up any questions in relation to those specific areas of responsibility that they have. And I should also say that we have some questions from ERSCAG as well, the Ealing Reclaim Social Care Action Group, which we'll take. But if I go to you, Councillor Newstab, first, and then pass over to Kerry after that.
Yeah, I won't use much of your 40 minutes, but I wanted to take the opportunity to introduce the work which Kerry will speak to, but I'm sure Avtar is responsible for. And I just wanted to say that, and very much from my personal experience, having visited Harrow Care Line probably about 6 to 7 weeks ago, and having met the team there and understood the benefits that working with an accredited registered provider are bringing, particularly around the professional way that the team conducts their work, and the access to management data and information about our interactions and support that we provide for users of the service that we previously didn't have. Avatar and Kerry, I'm sure we'll talk to more about the specifics of the report, but I was absolutely convinced of the professionalism, the compassionate approach and the experience of the team that I met there. They've been providing an excellent service for Harrow residents and others for some time. So I wanted to contextualise the report by just saying that that's been my experience, and there's further work to do, but my sense is that we're really bedding in a very good commission service for what is often many of our most vulnerable residents, and that really there's great potential in expanding and improving the existing telecare offering in ways that will improve that further. So I'll pass over to you, Kerry, and I'm happy to respond again, having been there, if there's any further questions that people have along the way.
Thank you, Councillor Newstub, and I will be passing straight to Avatar because she's done a huge amount of work in a short amount of time with this project, and just to really recognise the size of the challenge and the outstanding work that's been done by the integrated commissioning team in this space, I think is really important. So over to you, Avatar.
Thank you, Kerry. Okay, so absolutely agree. There's been a lot of work done to embed and transition the service over from Ealing Careline to the new Harrow Careline service. That's been done in partnership with both the Ealing Careline and the integrated commissioning team and our social work frontline colleagues. So thank you both to Ealing Careline, because if it wasn't for them and their expertise, the transition could have been in a different position. I think it's really important that we acknowledge what the new service is actually like. So when you describe a Careline service from an end to end, there's actually 4 parts to a Careline service. So that's kind of the intake, the assessment and the triage, identifying the needs and identifying how we can meet those needs to kind of maintain your independence, so you can live life the way you want to, the way you choose to, and actually have access to the community. So that's one part of the service which has been delivered by Ealing Careline. The second part is the installation of equipment, the maintenance of equipment, and collections of equipment when it's no longer used, and the recycling. That in part has been delivered by Ealing Careline, but has also been delivered by our community equipment provider, NRS, for our more complex services that we have and our more complex equipment. The third part is the monitoring. Ealing Careline would monitor the alerts of 24 hours, 7 days a week, including bank holidays. That has now been delivered by Harrow Careline, and the data in this report talks about the intelligence that we are getting from Harrow Careline about our service users, our residents, key data which we can actually proactively reach out and engage to kind of maintain independence and improve the care that we provide. The fourth part is the response service. So when alert has been raised and there is a concern, the Ealing Careline service would do an on-site response service. That's now been delivered in a different way. So there are 4 essential parts to the service. We have continued under the new arrangement to provide the 4 parts with no break in service, but in a different way. And one of the key differences in the new service is that we are very rich in our intelligence that we get. We know more about our residents than we had 6 months ago, 9 months ago, a year ago. So we're now getting trend data. First time for a very long time with Careline, understanding key points, our frequent callers, early detection of any changes in conditions. So it's, and that's really, really important when it comes to prevention and delaying the need for care as well. So we are in a different situation, in a much, much improved situation. One of the key differences with the new service is that it's a lot more robust. There's business continuity embedded. The services are up to date in terms of its technical capability as well, so it's digital ready, without the need for a significant financial capital investment from the partnership to get the old system up to date. So there are some cost efficiencies with the new system, as well as an improved outcomes for residents in terms of, in terms of delaying, preventing, and ensuring that there is independence. So the report talks about some of the key figures that we've got over the first 3 months. We focused on the first quarter of the service. The service went live on the 1st of April. And there's what we have now, what I can share with you is some of the key data. So we said essentially on the 1st of April, 1,100 service users went over to the Harrow monitored service. Since then, it has increased to approximately 1,600. And that's because we have, through working with our housing colleagues, we have moved over the sheltered residents over to a Careline monitored service, but we are getting new referrals on a daily basis. What we have done to encourage new referrals, that we're doing some training and awareness sessions across the partnerships. Triage and assessment is now being provided by adult social care, our front door, our localities, and our hospital discharge teams. And we are now working with our health colleagues, our health practitioners, our social care colleagues, and our occupational therapists to kind of increase awareness of the benefits of telecare, the benefits of monitoring, what the equipment can do for a range of services to increase referrals. And that's in train. This week, we trained our first batch of NHS colleagues. We've got 5 other sessions planned for October and November. Following feedback, we will continue to do that to raise awareness as well. So that's one of the first big differences that we've done since the implementation of the new service. In terms of monitoring, like Councillor Newstaff has said, Harrow is an accredited service, something significantly different from where our start point was. It goes through an annual refresh of its accreditation and a full 3-year cycle of accreditation as well. Part of the accreditation is looking at the policies, the processes, doing customer service surveys and interviews. Harrow provides Careline monitoring service for a number of local authorities, not just Harrow in Ealing, so they're very well versed, and they've got the systems, the data, the platform to provide the data that we need as well, and also respond from their own experience and their own expertise. We know on average we get 90 calls a day to the Harrow Careline service. If you look through the data and the slide deck, it does vary in terms of, sometimes you get 40 a day, sometimes you can get up to over 150 a day as well. And that depends on the weather, it depends on a huge range of things in terms of what's happening in the local community. But we've never seen that before, and it's really interesting to get that data to understand how we can change our services around perhaps having the twilight service, having a different service to kind of maintain the independence. So some of the things that we are getting back from the data on a daily basis is that you may have a resident who is raising an alert at the same time most evenings, and that's an indication of need. What we have done in response to that is we've changed the timing of a package of care. We have referred and we have worked with the residents in terms of accessing voluntary services as well. So it's a lot more proactive than it used to be historically. This is a preventative service, so the data that's actually in the report, there is a lot of what we would say that there's a lot, alerts that's been raised in error, or there's been repeat calls, or there's been system tests. Harrow Careline also do an annual call to the resident on their birthday, and that's one in terms of actually understanding the needs of the service user, updating the information that we have around nominated contacts, key information around key safe, access codes. So it's a really good way to kind of engage with our residents, but also make sure we've got a robust and up-to-date service and our information about them as well. We do get information about the type of calls that have been raised as well. So whether they're bed sensors, whether they're false alarms, whether it's window alerts. So there's a lot more information available. It's been the first 3 months, so it's a bit too early to start thinking about key trends. But this data comes to us on a monthly basis. We meet as a partnership on a monthly basis as well, where we can actually work through any issues or actually kind of implement new changes as well. This is an ongoing process in terms of the way we are trying to deliver a service to meet the needs for our local residents. So that's kind of the monitoring service. Second to the monitoring service is a response service. So what do you do when there has been a alert raised and there needs to be an on-site response? We have working with 5 providers across the community in Ealing. They have all been vetted by our procurement team and my team in terms of our commissioning. So they've got CQC ratings of good or above. They live locally and they can guarantee a response time of 45 minutes. That 45 minutes is really important because it's linked to the TSA accreditation in terms of what your response times should be. At each response, at each on-site visit, we get a fact sheet of information back, and that will detail the time they were on site, the time they left the site, what was the problem, what did they do to resolve the issue, and any recommendations. That is both fed back to my team, our community equipment team, and to Harrow for that information and intelligence gathering, and we will act upon that. Some of the examples of what's happened with the responsive service is people have fallen over. When we think about people falling over, we often kind of visualize them falling in the middle of the room. That doesn't really happen. They tend to fall by a door, so access is really difficult. Picking them up is really difficult as well. It takes a lot of time and a lot of expertise in manual handling to safely pick up an individual from the floor. Our responder services are trained in manual handling, they're trained in first aid, they're also trained in personal care. And that's really important because if you have fallen and you've got mobility issues or you're frail, personal care is absolutely vital. From my experience, when that happens historically, that would convey to a hospital visit. We have stopped the hospital visit. Anecdotally, I do talk to some of the Ealing Careline staff because they're employed in different roles across the local authority. Ambulance call-outs was about 3 or 4 a day. We have now, through this service, reduced down to 90 in the first 3 months. So, on average 1 a day, but I'm sure that's subject to variations as well. There have been no kind of conveyances to the hospital. There have been calls made to 111. There have been updates in terms of contact information, and there's been updates to the social care in terms of what we can do proactively to avoid future falls or future welfare calls. So we are getting richer information as well. That's the response. So that's kind of the gist of the service. Now the data is in the report. You're more than welcome to kind of question any queries that you have. We do have a plan to move forward. So this is a service which we have embedded. The partnership is working really, really well, but we're very ambitious for our residents in terms of how we want to deliver a good quality service. One of the main projects which we are now working on is the digital switchover. All our current equipment has been analog, and that's no longer will be used from 25-26. So we are going through a change program to upgrade the information. Harrow are providing assistance with NRS on that. At the start of the project, we had about, I'd say, 1,000 people on analog. As from today, there's been 669, so we're making significant progress in our digital switchover. We are also getting continual data cleansing from Harrow. Whilst we cleansed the data before we transferred our 1100, so we went from 2000 to 1100 to Harrow, there's been about 10 or 15 further case closures because of change of circumstances or people have moved on. So we're getting information in real time, we're getting richer information, the service is improving, the feedback in the report, so the survey's been carried out and we've had some initial feedback about the impact in terms of safety, how they feel and how quick and responsive the service has been. It's all there in the report to see. The survey we closed in.
I think that's been really comprehensive,
Sorry.
actually,
I got a lot to say
Abdar,
about
in
this,
terms
yeah,
of, I
yeah.
know you've lived and breathed
Yes.
all of this, but I'm very mindful that I want to offer the opportunity to the panel
Yeah.
to ask questions. So if there's one or two kind of key highlights. Or,
Yeah, of course, yeah. All
Yeah.
I was going to say is the survey will be completed and ready for analysis in December. So we're happy to share the data. Yeah. That's
amazing.
all I wanted to add. Yeah.
Thank you so much. Really appreciate it. So I've got indications from Councillor Kate Crawford. I'll take them in threes. Councillor Conti and Councillor Baines online as well. So Councillor Kate Crawford first.
So thank you. With regards to the action taken in response to calls, there were 6 identified as access not given, as no password was provided. But if someone's had a fall or memory loss, just can't call, it's very forgetful. I couldn't remember a code I should have had today. No idea. I haven't used it for a couple of years. So, what work is done? What follow-up work is done with the caller, carers?
So
it just doesn't look good, does it?
So that's more around the oh, is he? Sorry.
What I'll do is I'll take them in.
Turn this off.
So Councillor Crawford, if you cover off your questions, and then I'll take them in threes.
I've got quite a few, so I'll come back a few times. That's fine.
Yeah. Okay, Councillor Conti, over to you then.
Thank you. It was really interesting hearing about the whole implementation phase. I guess one of the things was obviously the survey, or the comments about the survey in the report. Obviously, there's a snapshot of a few comments. Clearly, there was a lot of anxiety about the rollout of the programme, and I guess sort of retrospectively, could things have been? Is there anything that could have been done differently, or lessons learned in terms of about how that was approached, and the sort of the period of consultation, etc., sort of earlier on that may have made that transition in terms of the perception from users a better experience? I'd be interested to hear a bit on that.
Lovely. And then Councillor Baines online, I know that you've got some questions as well.
Yes, thank you. Good evening, everyone. Thank you, Councillor Newstab and officers, for your very detailed report. It was very interesting to read. So my question that I have is, given the transition from the Ealing Careline service to the Harrow Careline service, what specific steps have been taken to ensure that vulnerable residents are receiving the same or better quality of service as before? Have there been any reported incidents or service failures since the transition? And just my second question was, with the cost of the new Careline monitoring service being £260,000 per annum, what long-term plans do we have to ensure that the service remains financially sustainable? Would there be any kind of plans to introduce charges for the service? And if there is, would that be communicated to residents? Thank you.
Thanks. I'll come your way now for some responses. Who wants to start? Kerry, I'll come to you first then. Oh, if you just pop your microphone on, that'd be grand.
It's the wrong one. Sorry. Lovely. So access not taken, that's more around safety and making sure the right people have access to the property. The process is Harrow will actually contact the nominated contacts that they have. So every telecare service user, where possible, will have up to 3 nominated individuals which Harrow can call upon in an emergency. If that doesn't work, they will do an on-site visit. So 6 out of the 90 calls a day they get is little in comparison, but they follow the processes that have been determined by the national accreditation body. But I can certainly get more information about that. Yeah. Sorry, yeah.
Do you want to?
So in terms of, so what can be done differently, I can do that. Yeah. Sorry. So in terms of Councillor Conti's question about some of the lessons learnt, we had a very short time to implement a new service, 3 months in total from the decision made to close the service and the notification given to social care. There was intensive pieces of work done around finding a suitable provider, working through the governance route, cleansing the data and writing to all residents to inform of the change. Not, as much as we tried, not every resident was contacted at the right time in the right way. So there are lessons that we have learnt in the way we can do things differently. We will continue to kind of learn from this, and we are learning from this in terms of actually as we are now trying to kind of improve the service and establish different ways of working.
If I can add as well, Chair, in terms of the lessons learned, we need to remind ourselves that the Careline service, we had a number of serious concerns about the quality of the provision. We had an internal provider concerns process, which I hold as the statutory DAS in terms of the quality of the service that was being provided, because there had been some significant concerns. And whilst it was a rapid transition and a lot of work between Avatar's service and Jess's service, and it's really important that we work together, it was really important that we got the improvement in the quality of the offer, because, as everybody said, this impacts a huge number of people in the communities that we serve in Ealing. If I can just go back to Councillor Crawford's point, it's 6 out of a total of 3,893, I think, in terms of the proportion. I do take your point, but it's not 6 per day in terms of where the access not given, no password provided. Can I take? Does that cover your question, Councillor Conti?
I have a slight follow-up, if that's sort of a response.
I think what we'll do is we'll do the round of questions, and I think I already know that I've got to come back to Councillor Crawford. Councillor Steed has my ear because he's next to me, and then I'll come back to you, Councillor Conti.
Apologies, I was trying to take over chairing then. That's certainly not my role. In terms of the assurance for vulnerable residents and ensuring that we get the quality assurance checks in place that we heard as the third question, we've got significantly greater levels of data and information about the quality of the service provider, that we know that it's an accredited service. We can actively see regular reports from the provider in terms of the offer that's being provided. And again, as the statutory DAS, I'm significantly more assured with regard to the quality of this provision. In terms of the costings and the charges, we're still in a suspension position in terms of charges for people who use the service. That will be reviewed, and we'll be looking at that shortly. In terms of the cost of the service, as we move into the digital age, we think there's going to be significant opportunities for us to be using different types of technical equipment to support people remain as independent and well in their own homes for as long as possible. And this gives us the platform to do so, and that supports the business case for this model.
Lovely. Councillor Newstab.
Yeah, I just wanted to add really briefly, because we talk about data and reports a lot, and that's great in a management setting. But what that actually allows us to do is to be far more personal and responsive in the care that we can then provide. So it is no small thing to be able to understand the time at which we receive most calls, and to be able to respond to that on an individual basis to adjust their care package. So there's elements like that strike me as really significant. And having spoken to those people who are on the phones all day, they are very they know our frequent flyers very well already. They're building personal relationships with both the users of the service and their carers. And I think that combination of the data and the reporting and being able to adjust the packages that we have and the way that our wider social care teams can support those residents is a really powerful combination of both data and that personal care that they can give.
Lovely, thank you. So Councillor Crawford, then Councillor Steed, then Councillor Conti. I'll try and instill some order, shall I?
Somewhere in the papers, I recall 2 residents complained about the equipment, and I identified that it's going to be good amount of recycling, the maintenance and the recycling, and that's important. But how will checks be done? How will Ealing know? And will there be any information put on the recycle? Because if whatever it is, it could deteriorate, more quickly, no matter how good it left Harrow. So I'd just be interested in, because a lot of, I want the recipients to actually know who to contact and not to feel bad about it, and to realise it might not be Ealing. They may have to, it might be a different kind of number. Thank you.
Thanks, Councillor Steed.
Yeah, thank you, Chair. It's just all picking up on a point from Councillor Conti's question. And it's a question I've tried to ask twice at full council, but clearly that's the wrong forum to ask a sensible question or get a sensible answer. Why, Aptar, you said that the time was so short, but what I don't understand and haven't been able to understand and get an answer about is, certainly in the previous meeting, officers have mentioned that they've been talking about this change. I think there was mentioned a bit, the conversations going on a year ahead of the change, and maybe it was less than a year. But I mean, the whole thing seems very hurried in the end. And what I can't understand is the process and how the process between adult social services and housing works, and where the initiative came from for the change. And I say that process, which I just can't get a grip on at the moment, but I'm sure I will shortly.
And then final question in this round, Councillor Conti.
It was just to follow up. My understanding that clearly is that there was a problem, an inadequate service that needed intervention, so that it had to change, had to move quickly. But I guess what was the oversight of the original service that we had that meant it got to the point where it had to be done so quickly? So were there sort of warning lights coming down the road? So, were there interventions that were done at an earlier point? They didn't have to mean that everything had to be done in January and then rolled out in April. I guess when were concerns first? When did you become first aware of the concerns?
Kerry, shall I come to you first?
In terms of are you able to take the first question about the equipment issue from Councillor Crawford, and I'll do the second.
Yes. So the concerns raised around the equipment from the two residents was as a direct result of the survey that took place for the TSA accreditation. And as soon as the results came in, Harrow contacted the residents. It was one about the knowledge of the equipment. It was old equipment as well. And second, around understanding what the use of the equipment can be. New equipment has been put in place straight away. It's digital equipment. It's in terms of its reach, it's not just in a one room. So the old equipment had a base unit in one room, whereas the digital works around the property. So it's a lot more robust. That was resolved very, very quickly. In terms of the recycling, we have a community equipment provider which will safely, and in accordance with the regulations, recycle the equipment in the most appropriate way.
Can we have it through the chair? Is that okay? So Kerry, that's fine. So I will, no problem, but I would like to chair the meeting. Thank you. Just on the monitoring, Avatar, if that's okay. So
monthly monitoring meetings take place with all elements of the service. So we get feedback from our triage and our ordering service, our frontline social workers. We get feedback from Harrow, our responder service, and also our community equipment provider. So this is an integrated service where there's different partners that deliver to the telecare service. We get feedback on a daily basis sometimes as well, and that's all triangulated and discussed at the partnership level. Spot checks can be done within reason. Due to data protection, we can't be listening into phone calls. But the TSA accreditation does give us some sort of assurance as well. But we get a lot of data. We've done site visits ourselves to the Careline service 3 times since the start of the service as well, and that will continue. During the first 3 months, we had weekly meetings to embed the service. We have now moved to a monthly basis. as one part. The second part is due to the digital rollout, we are having fortnightly meetings on a separate topic. So information is free flowing and in real time.
And Kerry, on Councillor Steed and Councillor Conti's points.
Thank you. So just to remind the members of the committee that the previous provider, the Careline service, was provided by Ealing Council. Adult social care were the customer, and the service was provided by colleagues and partners within the housing department. So there's a clear separation in terms of function, in terms of the service. In terms of the decision-making process, from my statutory perspective, the provider concerns that were raised by adult social care relating to the quality of the offer of the Careline service sat within the purview of our duties under the Care Act in terms of quality of provision and commissioning arrangements to ensure that we get good quality services for the best outcomes and that we're not putting our customer base at risk. These were raised within the adult social care function and obviously shared with the Careline provider and the hierarchy within housing so that they're aware of the concerns and issues that we had. And we were working closely with partners in housing to try and improve the position. The improvement from an adult social care perspective was minimal within the period of time that we're working with them. And it was approximately 6 months. I think the decision was taken in the November 23 to actually progress the closure of Careline. And we'd been having active provider concerns for approximately 6 months prior to that. So the formal decision-making process was a delegated power to the Director of Housing, who was able to make the decision in terms of the closure of the Careline service. And obviously we worked very closely with our housing partners as that decision was taken. But I think the bit in terms of the timescale and the consultation is there was a number of drivers here. There's a driver about internal decision making, ensuring that we do consultation and engagement with staff and potential risks of redundancy. There's all the commissioning commercial requirements around how we engage with the market, who do we commission from, how do we do a market test to see which is the best provider. We could have taken a year, but I think we did exactly the right decision to push it through quickly from a statutory DAS perspective in terms of the quality of the offer and the improvements that we've seen since the decision has been taken. So there's the customer, just from oversimplifying the situation, there's the customer provider perspective internally within the council, my decisions in terms of the safeguarding issues and concerns that have been raised regarding the provider service. There was the issue in terms of the delegated decision being taken by the housing director, but we did work very closely throughout. We did understand that these were going to be very challenging timescales. There was a lot of consultation, there was a lot of engagement. We can always improve on that. If we'd had 6 months, maybe it would have been more consultation, but as a process, in terms of safeguarding vulnerable people, I'm fully assured that this was the right route to take.
Thank you, Kerry. Councillor Steed wants to come back, and then I am going to take the ERSCAG questions, and then we will have to move on, colleagues.
Kerry, I'm not questioning your decision making. I'm just interested in the process. Can I just emphasise that? Thank you.
No, that's very much appreciated, Councillor Steed. Thank you.
As I said, I will now just call on Alex Cowan from ERSCAG. Alex, if you want to ask all three of your, I know you've got 3 questions because you've kindly provided them to me in advance. If you want to ask all 3 of them at the same time, and we'll make sure that we get a response for you.
Thank you.
Thanks.
Thank you, Chair, for accepting the questions from ERSCAG. Why did the Healthwatch Enter and View study not take place as planned? Although the Careline report does mention that this study will now take place next year, this will miss most of the setup and transition arrangements which caused so many difficulties and much confusion this year for Ealing Careline users. And I think it's really important because we are having reports that service users are not getting the regular calls that they used to get from Ealing Careline to check that their pendants are still working. Secondly, we understand that the responder service is being undertaken by 5 domiciliary care agencies. How were they chosen and who is monitoring their work? The information provided in the report is largely anecdotal, presumably provided by the agencies themselves, and there needs to be a much more rigorous analysis of how this service is working. And thirdly, what are the statistics for those awaiting social care assessments and reviews? Did the CHC inspectors comment on these waiting lists? And is there still an extra backlog due to the closure of Ealing Careline? Thank you, Chair.
Thank you, Alex. That's a great, and I think you meant CQC in your last question.
Oh
so
yeah, sorry, the CQC.
no problem at all. Kerry, I'll come your way.
Thank you, Chair, and thank you very much for your questions, Alex. In terms of the interim view arrangements for the Harrow Telecare service, the Health Watch interim view has not progressed due to data protection concerns and the ability of Health Watch to carry out an interim view in essentially a telecare office space is not deemed appropriate. However, as Councillor Newstubbs mentioned, she's visited telecare with Avatar, and Avatar's been there on a number of occasions. But further opportunities for surveying people using the service can be considered in the coming year. But from a Health Watch perspective, that wasn't deemed appropriate.
I'm going to carry on with Kerry, and David, we can come to you afterwards.
Thank you, Chair. Thank you, David. In terms of the responder service and how the procurement of the domiciliary care agencies, the agencies were procured via our mini competition on our domiciliary care dynamic purchasing system. This is the tried and tested way that we engage with domiciliary care providers and set up contracts with them. So there's a very clear process. We followed the standard commissioning practices to procure the services. In terms of the last question, the current position is that in terms of social care assessments and reviews, there are currently, as of last week, 18.6% of people in receipt of services who have an overdue review. That's based on the CQC standards, where the overdue review period is set at 12 months or more. The average waiting time for an assessment is, as of last week, is 108 days. However, it should be noted that those waiting for assessments are under regular management scrutiny as part of our triage processes and reprioritisation of work. The waiting times for assessment and reviews were discussed with CQC, and the Council's position is that our performance compares favourably with other local authorities, both nationally and across London. There are no backlogs associated with the transfer of the telecare service to Harrow. That was all completed, I think it was about 8 weeks ago. Yeah. Thank you, Chair.
Thanks, Kerry. David, you wanted to add?
Yes, I just wanted to reiterate Kerry's words. The reason we are not going forward with an interim view is through mutual agreement. Our interim views are smaller in scope, and Careline deserves its own dedicated project, which we will be undertaking next year. Health Watch, we are a small team and we work very hard. We are currently halfway through our work programme for this year, and we just did not have the time or resources to start an additional study.
That's really helpful. Thank you, David, and Alex, thank you for those questions. We are now running overtime, so I am going to bring the item to a close, but before doing so, I'd like to say, in terms of the ongoing monitoring of the service, I would like a report to come back to HASP in 6 months' time, just in terms of monitoring the performance on an ongoing basis, and then I would expect that to fall within the Cabinet members' brief moving forward. So as we would expect regular performance monitoring, but given the the kind of public interest and from partners. I think that would make sense. And Councillor Steed did whisper in my ear about a potential visit for HASP potentially around the care line. So perhaps that's something we could pick up. I don't know how Harry would feel about the whole committee descending upon the service, but I think we can maybe figure out how we might do that moving forward. So thank you very much, colleagues. We will now move on. We've still got two quite significant items on the agenda, but just in terms of those recommendations, are we happy for the report to come back in 6 months, and we'll try and progress that that visit to Harrow Care Line as well. Super, thank you very much. So the next item is about, well, it's twofold. It's about the long-term strategy for Meadowhouse Hospice and the exciting developments in terms of the Community Diagnostic Centre at Ealing Hospital. So it's sort of in two sections. Dr. Piers Milner, the head of strategy at Northwest London Healthcare NHS Trust, is attending online to introduce the Meadowhouse Hospice strategy, and he's being joined by two colleagues, Dr. Trina Sani, the clinical lead, and also Randall Jones, the nursing lead. The strategy itself, you would have seen, was circulated after the main agenda items, and apologies for that. The dates just didn't quite come together in the way that we had hoped. The panel may also want to just be aware that from a North West London Joint Health Overview and Scrutiny perspective, we have been receiving reports about the proposed new model of care for adult community-based palliative care services, and the committee, as in JOSC, will be consulted on any potential changes further down the line. So we haven't yet met during this civic year, but we'll be sure to make sure that colleagues are informed of any developments in that space. So if we deal with the Meadowhouse Hospice section first, and then I'll come to Mark for the bit on the Community Diagnostic Centre, if that's okay. So Piers, I can see you online. You're very welcome. I'll pass over to you.
Perfect. Thank you very much. Am I coming through okay and clearly?
Loud and clear. So no, that's all grand. Thank you.
Perfect. Thank you very much for inviting us along to talk about the Meadowhouse strategy. So I'll assume the papers are all read and the like, so I'll very, very briefly introduce it before we open up to questions. And so Meadowhouse has been providing high quality patient-centred specialist palliative care to Ealing and Hounslow for the last 35 years. And recently it's become increasingly clear that the service has hit a bit of a crossroads in terms of increasing demand, staff shortages. It's a very specialist workforce, and those two combined prompted a bit of support from the trust strategy team that I'm part of. So working closely with Trina and Randall, who are also on the call, we started this work about a year ago or so to really understand some of the challenges facing Meadowhouse and come up with a response and a strategic response. So that involved a long period of engagement, both with our teams, with partners, to understand some of the real challenges facing Meadowhouse. And off the back of that, we've come up with a strategy that we've named Partnering for Excellence in Specialist Palliative Care. And really that highlights the two core elements of it, in that we are a specialist palliative care provider, but we know that we can't go alone and we need to support the broader end-of-life care system. And so it's how we're partnering to actually deliver that. And you will have read we've got 4 main objectives, and the first really is about refreshing and restating our high quality specialist palliative care, but at the same time working with partners to and supporting them in delivering the non-specialist elements of care. The second objective is around how we provide that care in the most equitable and sustainable way. The third being actually how we're supporting our employees, as we had a question related to the strategy itself, noting the staff survey results, which show quite poor staff satisfaction, and so a real focus on how we can become a higher quality employer. And then finally, the fourth objective that really just drives home that partnership element of how we actually work together as a system to provide the highest quality end-of-life care for Ealing and Hounslow. So that's my brief overview. Trina Randall, I didn't know if you wanted to come in to add anything onto that before we open up for questions.
I don't think Trina or Randall have indicated, so that's been really helpful. Thank you, Piers. I know that Councillor Crawford has a question. Any other questions? Councillor Conti, we'll do those two first.
Oh,
sorry, and online, please. Sorry, Chair.
Online as well, Councillor Baines. Yeah, we'll come to you after Councillor Conti.
Sorry, Chair, I've got 3 questions. They're brief. Oh, thank you. Now, good evening, Piers and Dr. Sani and Randall. I have been inundated by constituents and previous users of the service and relatives of people who have experience of Meadowhouse Hospice over the last 48 hours with, I don't know where this got started, but asking me to stop any secret plans to close Meadowhouse Hospice. I want to be absolutely clear about this. What we're talking about here is not closing Meadowhouse Hospice, isn't it? It's about improving on a wonderful service that we've got. And for the people who've tuned in to hear that this evening because they can't be here, can we just confirm we're not closing Meadowhouse Hospice? We want to build on what we've got. That's right, isn't it, Piers?
Yeah, we're
sorry, Piers. I'll take it as a round. So if you want to ask your other questions, it's just otherwise the management of the meeting becomes unwieldy, and I'm not having that.
Sorry, can I just? I didn't hear Piers' answer, but I'm assuming he's agreeing that yes.
So Piers will respond to the question, but I'm taking a round of questions. So if you want to ask your other questions,
right. Okay. So now this is okay. Right. I'm assuming that Piers is going to say yes because he was nodding at me and I'm looking directly at him. So in assumption of that, can I say that the quality of this service is exceptional? And I speak from a little bit of personal experience, given that my 2 colleagues who unfortunately are no longer with us, a previous chair of this panel, Councillor Paul Woodgate, and indeed our previous portfolio holder and many other things there, Councillor Patricia Walker, had extensive experience of Meadowhouse Hospice, and indeed we donate substantially in their memory. So I just wanted to ask if we could pass on the immense consideration and approval and support and recognition of the dedication of so many staff members at Meadowhouse, and if that could be reflected and reported back, because I am concerned about that staff recognition and number in the survey that you've referenced, but I just wanted that to be communicated. And finally, Chair, the element that's interesting to me is how we move on and how we build that better service, particularly with the financial risks and, as was referenced, that challenge between people needing to use the service more and the stretch element. So I think there's a role going forward, and I'd be interested to hear how we look at that. Thank you.
Thanks very much, Councillor Crawford. Councillor Conti.
Thank you. It was just really on the staff element. Just a bit more information. I know in the report it talks about we'll optimise our workforce, deliver our new specialist palliative care model, It talks about recruitment strategies, etc. It was just really about whether you're able to, are you looking to expand your workforce, or are you able to deliver within what you have, but sort of restructuring? Because it sounds like, obviously, with sort of low staff morale, etc., that, you know, everyone feels quite stretched. So are you looking at reorganizing to enable the people who already work there to perform better and feel less stressed? Or is it that you're planning to increase the size of the workforce? I wasn't quite clear from reading the I think it was page 16 where it outlines it. So a bit more information about that would be helpful. And just, I think, to echo what Councillor Crawford said, you know, lots of our patients in the practice I work at use Meadow House, and, you know, I think the interface between primary care and Meadow House, I think, has always been excellent. And, you know, lots of families that we've spoken to, I speak to regularly, always have good things to say. So I think it's an incredible service.
Thank you. And then finally in this round, Councillor Baines.
Oh, hello. Thank you so much for your report. I would just want to ask 2 questions. Number one would just kind of, how would we ensure that residents who might experience gaps in the service provision for non-specialist palliative care? That was kind of my number one thought on it. And number 2, because I'm a councillor in Southall, I just wanted to ask how, you know, it would be ensured that resources were adequately secured so that there wouldn't be any disparities in the quality of care provided, especially in marginalised communities. So that's kind of my thoughts around the topic. Thank you so much.
Before I bring Piers in, I think Mark, you wanted to just come in.
Thanks, Chair. Yeah, I just wanted to sort of respond, if I could, helpfully to Councillor Crawford's point there in terms of the, you're absolutely right in terms of that commitment and that future of the service, which is exactly there. And I hope that comes through in the board and the executive and our chief executive's introduction to the piece as well, where she's very, very clear about that commitment for the future, just to reinforce that point.
Lovely. And Piers, I'll come to you now on all of the questions with your colleagues as well.
Piers, my camera's not working. Do you want me to pick up on some of those questions?
Yeah, Trina. So I'll touch on, I'll touch a little bit on the first point that Mark's already pushed at. So, you know, certainly there's no aim to close, and actually, as part of this, there's been quite an investment by the trust into the service itself, and so that is restating the commitment of London North West towards Meadow House. Trina, if you wanted to come back on those positive comments about the clinical care, you know, that's nothing to do with me. So.
Well, thank you very much for your comments. We do try our very best with our very stretched and overworked workforce, but thank you for those comments. Just to pick up on some of those points, first of all, in order to manage our workforce in the future, we are doing both. So we have, on the back of the strategic plan, we have managed to secure some money from a business case, which is going to allow us to increase our CNS workforce in the coming year. On top of that, we are hoping to restructure. We are planning to restructure so that we have a greater skill mix within the team. So including band 6 nurses, as well as some posts which will be band 6 to 7 development posts. At the moment, there is a national crisis of band 7 specialist palliative care nurses, and we appreciate that. I think our plan will be to develop our own nurses in the future. So in answer to your question, there is going to be restructuring as well as an increase in our workforce due to a successful business case within the trust. And just moving on to the other point that was made about supporting non-specialist palliative care. I think the first point I'd like to make is there is no immediate change in our service that will leave any patient in Ealing or Hounslow without our service or our support. But we do hope over a period of time we'll be able to skill up our primary care colleagues as well as other community professionals to provide better end-of-life care. And we will always be around. We have a 24/7 service, consultant-led, to provide advice to services both in hours and out of hours. And just part of our plans going forward is also to focus on equity and to ensure that we do make sure that our service does provide care for all the groups that we should be doing, that we should. I think we already are quite good at being equitable, but I think there's always more work to do. And I think going forward, we hope to collect some data around this so that we can ensure that our service is meeting this need. Randall, I don't know if you have anything to add to that.
Just briefly to say, I think we're already moving forward. So, the money we got through the business case, we're already filling the posts that came with that, doing different roles, looking at different ways of working, which will have an enormous impact on the sort of service we deliver to the people we look after.
Oh, maybe just to mention that I know one of the questions that was asked was about our staff survey and about morale and our staff feeling valued. I think just doing this piece of work, this coming up with a strategic plan and being able to take this forward to a successful business case has already improved morale. I think that our staff knowing that even though things are difficult, more staff are likely to be recruited has been very helpful as well. And there were some specific issues that our staff were facing, such as car parking, which have been resolved, which I think also has helped. And we've slightly changed the way we we work very closely with our staff. We are part of the team. And any issues that are flagged to us, we do try and resolve as quickly as we can. And I think our greater and improved links with our trust has helped that immensely. It means we can escalate problems and get them sorted out much more quickly. So thank you to Piers in particular, who has done a lot of work in that area for us.
Thanks. I think there was also a question around catering for diverse needs. I think Councillor Baines raised that. I just wondered if someone could come in on that point.
So we do. Our workforce is quite diverse. So we do have lots of cultural and language experience within the team already. And we do use interpreters if we need to. I don't know. I think so. That's one sort of aspect. I think the other aspect is we do work very closely with other teams within the community, such as the learning disabilities team. So if there are any patients, so we sort of make sure that we have good links, so that should we need to deploy them, we are able to do so. And like I said, going forward, we do hope, we don't have much data around this at the moment, but I hope going forward we'll be able to start collecting some data around this as well. I don't know if that's answered the question.
And can I just come in as well?
Yeah, of course.
So one of the, you may have seen in the strategy itself, we have a number of KPIs, and one of the things that we're quite proud of in London North West more generally is we've developed a sort of a novel indicator around equity of care, which we call our equity index, and it's been the likes of the Healthcare Service Journal, and we're a finalist for the HSJ sort of equity awards off that, and that allows us to quantify the equity of our services. So what we're doing with Meadow House is looking at, on the local population, the variance of ethnicities, of levels of deprivation, and they should be in line with the local population. And any areas where we see things being slightly off, then aiming to do some focus work around that. And finally, as well, in the strategy, some of our longer term goals are actually starting to get a bit more of a community presence. And once we have that stability in the workforce, how can we start to be more present in the community as well, whether that be in faith areas and really sort of building up that community presence.
Thank you. I'm not seeing indications from colleagues. We do have a question from a member of the public. So Sarah, would you like to come forward? Sarah Boston from Ealing Save Our NHS has notified us of a question. You can, there's a chair just by Councillor Newstub actually. And I'm sure Councillor Newstub will help with the microphone as well.
There you go. Hi, yes, I'm Sarah Boston. I might declare an interest. Some years ago for Channel 4, I did a documentary about the Marie Curie Hospice in Hampstead. I did the documentary first,
I'm
and
not
then
sure. I'm not sure you need to declare an interest. You might want to circulate the link.
anyway, that's So, but I thought filming there, you always think they're giving you a good impression. 4 years later, my friend died there, and I realised the quality of care was exactly as I'd been told. And what worried me reading this report, and they picked up on it, but rather they recognised staff dissatisfaction. But in the report, it actually says staff recommending our employment only 25%. That is a terrible indictment of the employment of people there, as far as I can see. If only 25% could recommend working there. And what I want to know is what the very specific measures about improving that, about making staff feeling valuable, about career progression. I recognise there are difficulties in recruiting in the NHS generally and in palliative care particularly. It's the mental health and psychological well-being of the people who work there, because I know from the Marie Curie that was something built into, the people working particularly with end-of-life patients. And so I'd just like to know, rather than just general waffle about what we intend to do, what specific measures are already in place and what's going to happen to improve staffing there.
Thank you, Sarah. And I think that's a really specific question. So it requires a specific answer about the measures and the actions that we're taking. So Piers, do you want to kick off on that?
Yeah, I'll start off before handing over to Trina and Randall. So that metric is from our annual staff survey. So it's a big part of the NHS, and we get about, it's about to come out for the next year. And we also have quarterly surveys, which are a little bit smaller in scale. And actually, thankfully, what we've been seeing through this process is we've already actually picked up quite a bit on that. So I think when we last looked, we were actually more at the 55%. So we've almost seen a doubling of the percentage of staff who would recommend our employment. And I think that's testament. We've mentioned some of the things around the parking and the likes that, as this is part of their jobs, yet previously we were charging for parking, and we've changed that. There's a link within our charity, and we're trying to remove some of the red tape and access to actually how our staff can utilize the charitable funds that we generate to enhance patient care. And so those are two of the very specific actions that we've already delivered and are written in, and that have helped us move up to this. But I'll hand over to Trina and Randall, who might be able to go into a little bit more detail on that.
So some of the things that we have done to target the low staff morale is so we have very recently employed an educator, and part of her role is to develop the nurses that we have. So that's one thing, sort of the development. We also have encouraged education and training, and we are very happy to fund courses that the nurses would like to go on. We already provide clinical supervision for all staff actually, both formally and informally. The car parking was a particular issue around the original survey, which has now been resolved. And I think the other thing about the workforce is really, I mean, what we've done up till historically we have only recruited Band 7 CNSs, and this has made it very difficult for us when we can't recruit Band 7 CNSs. So we have very recently recruited other bands of nurses. So Band 6s will be joining our team, and we will be having some development roles so that nurses can move from one band to another within the service. And we're hoping that all those things will start improving morale. We also have plans to introduce what we're going to call a WOW forum. So have an opportunity monthly for our staff to have a look at the many compliments and cards we get, so that we can share some of the good work and that we all do, and have a time to reflect on it. Randall, can you think of anything else that we're doing at the moment? Trying to.
I think just quickly, I've been there for about 2.5 years now. When I got there, we had, there was a burnt out, exhausted workforce who were working massively over their hours. So I think just the permission that they didn't have to work 12-hour days when they were being employed for 7.5 was a bonus. So I think moving on with that and reiterating the positives about what the service they deliver, and that's why it's so lovely to hear the comments tonight, is that sometimes they can get ground down a little bit with the negativity. So it's always important that we do reiterate how important the role that they're doing is.
Thank you very much for that response. So Mark, I think you're now going to give an update on the Community Diagnostic Centre. So for those that don't know, Mark is the Managing Director at London North West Healthcare Trust, and this is has been an ambitious project, to say the least, hasn't it? So I'll pass over to you, but thank you to colleagues from Meadow House for that really informative update.
Thank you very much, and I can be fairly swift, I think, and then see if there's any questions on this item. And we've provided some slides and bullets to just give a sense of where the programme is at. And the headline, of course, is that the CDC opened last month, pretty much as scheduled, actually, following a period of sort of temporary provision of services before that. So we've had since December last year, we've had a sort of phased increase in some temporary services, and we've now got that new centre open fully from the 12th of August, which is excellent news. Worth pointing out that it is the major community diagnostic hub in northwest London. There are two smaller ones at Wilson and Wembley, but this one is a really sizable and significant investment, both in terms of capital equipment, but really importantly in terms of the people and the staff who make these services run. So over 100 additional staff have joined London North West as part of this diagnostic centre. It really does provide a step change in capability across all diagnostic services. Our hospital has one MRI. This provides an additional 2, so now 3, and that is going to benefit Ealing residents. We're seeing that already, and also residents across the whole of North West London, because this provides a broader service. A couple of final points, really. I think one of the reasons we were able to move at pace on this is we've used a repurposed building. So this is not a new build. We've put a little bit of addition on the sides, but we've repurposed what we had, and that enabled us to avoid having to move effectively and build from scratch. And of course, we provided dedicated access into this building. So there is no requirement to go into the hospital to enter the community diagnostic centre, and that's one of the fundamental principles of these diagnostic centres. I've mentioned about the staffing, where we've, I think, done a really good job in terms of recruitment, using some local staff, but also recruiting from overseas in some of the more challenged areas. There are 1 or 2 staff hotspots where we're still continuing to work, but we are pretty much at full establishment for the centre, other than in sonographers and radiographers, and we've got mitigations in place for both of those, so those services are running fully. Early patient experience, we're only a few days in, but it's so far really good. I've been in the centre a number of times myself and spoken to patients as well as the staff, and we're getting some really good feedback, and we're looking forward to welcoming Healthwatch back in October following an initial visit where they provided some really helpful advice and support. And the final point from me really would just be to reinforce, and I touched on it in the previous piece as well, around I think this is a really significant investment by London North West into Ealing Hospital in terms of the size and the scale of what it's brought to the area, and I think it just reinforces that from the board downwards in terms of that commitment to Ealing in particular, alongside the other hospitals that London North West operates. Thank you.
Thanks, Mark. Really appreciate the update, and of course, I should have said in introducing the item, the panel did go on an early visit donning hard hats, so some of us will be familiar with what perhaps the site looked like, and I do hope there might be an opportunity for us to come back and take a look at the progress that's been made. And I know the official opening is next month as well, which will be excellent. Questions from colleagues? Councillor Conti.
So it sounds really exciting, and it sounds like obviously it's a great addition. I'm just wondering about sort of whether, especially the referrals into this that come from secondary care, whether that then produces another bottleneck, because in terms of what happens next, if people have tests, then they have to go back to see the clinic to get the results and then go through about what the next action is. So obviously it speeds up that process. I'm just wondering what the waiting times are then for sort of subsequent outpatient appointments after that. So the person gets the test. Is it going to make it any faster then for them to have the follow-up outpatients appointment, or does they just get the test more quickly, but then they still have to wait 3, 6, 9, 12 months for them to actually see the specialist afterwards to go through the results?
Mark, I'll come back to you.
Thanks very much for the question. The answer is that it a little bit depends on which pathway the patient is on as to whether we can shorten that period whereby they come back for the next appointment by effectively almost taking a direct route rather than having to go through a number of stages, or for some of the responses then they will, for example, go back to primary care and then follow that pathway. So it is very much pathway dependent. I think the additional piece I would add to that is that now we have the centre open, the national team that provided the funding for this have asked us to look at a number of additional pathways, and in particular some pathways around breathlessness, around asthma, and some gynecological pathways where we can effectively take advantage of exactly what you've said. So avoid having to go through a number of stages before we get to whether it's an outpatient or a clinic or a specialist appointment, and actually use the information that we've got in the CDC to effectively move directly to that. So I think, and we're going to be piloting 3 of those before the end of this financial year, so in March 25, and we're just working through the detail of that now. So I think it's going to provide those opportunities there. And probably the final point is that there's a lot of future proofing effectively in what we've built here. So this is designed for the future, it's designed for additional capacity, it's designed to reflect the change in the demographic and the ageing of the population that we're expecting in Ealing and across northwest London. So it has got that capacity within it, and it's very much projected to have enough capacity for at least the next 10 years as we progress forward.
Any follow-ups at all? Any further questions from colleagues? Thank you very much, Mark. Appreciate the update. So we will move on to the final substantive item. And sorry, Neha and Vijay, I feel like we're often in this position where you're kind of driving us home. But we've got an update on the borough-based partnership and the impact of the Integrated Care Board reorganisation. So Neha, I'll come over to you in the first place.
Thank you very much. So I won't share the slides. And as you will see, there's a lot of content in the slides, and I'm not intending to talk through the most of it. It's there for everybody to be able to read and reflect on all of the fantastic work that the partnership as a whole has been doing. And when I say the partnership, the first slide just gives you a bit of an understanding of who is part of that partnership. So it's all our health and care partners on the front, on
across health and care, and we are working collectively to try and improve outcomes and make sure the teams that work in different organisations work more collectively and integrated in an integrated way, and we try and establish where there might be issues or concerns and work to improve the pathway, working with our frontline teams as well as our residents to do that. The pack goes on to describe how the governance structure works within our borough-based partnership, and you'll see that the borough-based partnership is not a legal entity at all. It is exactly what it says on the tin. It's a partnership of all of us working collectively, and we report directly to the statutory organisations and the boards of each of the providers. So it is based on a lot of good working and relationships and trust and transparency and honest conversations about where the concerns and issues are. I think I should absolutely say right from the very outset, the paper that is being presented and the reduction in the borough-based partnership workforce does not in any way impact on services in Ealing. It is the team in the borough-based partnership that is under the employment of the Integrated Care Board, the ICB, that is reducing, and I'll explain that in a little while. So the borough-based partnership right from the very outset started to define what were our priority areas. We've got integrated neighbourhood teams, which is about at a community level, how community services, mental health services, our GP practices, our acute partners and care work together to serve the population and try and improve outcomes for a population, defined population. Population Health and Inequalities Partnership, it's very much some of the work you've heard here about the health and wellbeing strategy, trying to reduce inequalities and working using evidence-based and piloting using funding that we're getting in centrally across the partnership to test and see what we can do to improve outcomes. Our urgent and emergency care portfolio is around looking at those seasonal pressures that all health and care partners are constantly struggling with, and how we work collectively to see what we can do to help each partner cope during those really pressured times. Our older people and frailty program, you heard today about the Meadow House piece of work, but that is an oversight. It's only recently started to form as a board, but we had a meeting today, and it provides that oversight and joined up of all of the different pathways and conversations happening around our older people and frailty and end of life pathways that happen, and make sure that they are all joined up and work together effectively. And our Children and Young People's Partnership is exactly that. We're trying to work as a collective to improve outcomes for our children and young people, and that includes a transition into adults. There isn't a specific mental health scheme, and that is because it is embedded right the way through all of those. And then the other part is some of our enabler work streams around what digital solutions are there that we need to start to think about how we work more collectively. What workforce have we got? And we've focused primarily on primary care from a partnership, but actually each organisation has been doing a lot on workforce. So we've got to bring all of that together. Our estates and then our engagement and involvement. I come here, I have been here over many years, and the pressures around estates has been raised a number of times, but we have a strategic estates group that oversees the whole partnership response, and it's a really, really tough position on that, and we're just doing whatever we can to try and help our frontline teams cope with the pressures. So that was all I was going to say, and I'll talk about the cuts in a moment. I don't know if any of the partners want to contribute.
Yeah, I just want to briefly touch on a couple of other areas. One is around population health and health inequalities. And in Ealing, we've been doing quite a lot of work under the Core 20+5 national framework in terms of looking at health inequalities. And just a couple of highlights for us in terms of what we achieve you will all recollect we had the man van outside the town hall here, looking at the health and well-being of men over the 40, and we had we had a very good response in terms of that opportunistic health screening of men, which resulted in a significant number of PSA prostate-specific antigen blood tests in terms of looking at and trying to identify prostate cancer. And the other one is around hypertension case finding. We do know that, not just in Ealing, but nationally, there was a drop in the diagnosis of hypertension during the COVID pandemic. So we've done quite a bit of work in terms of improving our prevalence of hypertension, because we know that if we identify hypertension, there is a high chance that we'll improve and reduce the risk of heart attack, strokes, and increase chronic kidney disease as well. So those are a couple of achievements. But I just want to also say that for 24-25, we've had additional funding from NHS England in terms of that transformational work, particularly in relation to Healthy Ealing team. And we've got a proposal to recruit 3 individuals who will support us in terms of looking at how we can be much more wide cross-sectional engagement, particularly in relation to our vulnerable groups, in terms of identifying health inequalities, but really importantly, having the BI skills to be really drilled down in terms of identifying and getting down to the data in terms of where are our hotspots around health inequalities in the borough of Ealing, to then be able to put down certain interventions to try and improve that. And then finally, we've been able to appoint a public health consultant within our West London Trust in relation to looking at community mental health as well. So we're really excited about what opportunities we will have in 24-25. And then I just want to touch on a primary care. As you can see in the slide that we gave, it's a very, very high overview of primary care in terms of what we've been achieving over the last 12 months. I want to make particular reference to our enhanced service, which is a single offer for all our residents in Ealing, and in fact all our residents in North West London. And what that's actually allowed us to do is, because it's been very much a PCN delivered contract, it's actually been a really good enabler in terms of the maturity of the PCN for individual practices within a PCN to work much more collaboratively in terms of the services that they want to deliver, but being able to deliver that within the entire PCN rather than every single practice trying to deliver everything with the constraints of premises and workforce. So that's been really, really important for us. And then in terms of immunisation and vaccinations, that constantly evolving. Everyone would have heard about the RSV vaccination, which is going to be rolled out, which actually in fact rolled out from the 1st of September for our over 75s and our pregnant women. Again, general practice has to pay. They are a key player in ensuring that we protect the population that we serve, particularly in relation to this winter, like we have done for every winter for flu as well. So that's been really important for us. And then finally, as you've been aware, we have come previously to Scrutiny looking at our North West London Access Programme. We re-looked at our North West London Access Programme. We are going to come back to Scrutiny, hopefully in November, to give some greater detail in terms of what we are planning to do. But just as a high level, we are going to undertake a very comprehensive engagement exercise through our PCNs and practices around the experiences of access into general practice. And that information will then enable our PCNs to look at how they want to look at access going forward, particularly in relation to quality improvement, change management, and really in terms of getting as much value as possible in terms of how we deliver access going forward. And then finally, as Neha mentioned, the ICB organisational redesign. Every ICB nationally have undertaken this organisational redesign. It's a 2-year organisational redesign. This is the first year of that. As Neha said, this is not going to impact on patient services either directly or indirectly. This is about an internal organizational redesign as part of the ICB and the individual teams that work within the borough. Yes, that there have been cuts. There will be cuts in terms of our whole time equivalent team, but we are confident that we will be able to continue to fulfill our functions and fulfill our duty with our core team. But clearly, we also have a central team within North West London that will support the local team in terms of what is expected of us. And our borough-based partnership, collectively, we will continue to work in the most effective way we possibly can.
Thank you, Vijay. I guess Chair's prerogative. The question that's on everyone's lips is the man with the van returning?
Yes, our expectation is that. So obviously, the man with the van came to Ealing, been to Brent, they've been to various other boroughs across North West London. We are definitely expecting our man van to come back to Ealing, but we are expecting them, and we're hoping that they'll come to another part of the borough to look at those areas where, particularly where we have our BAME community, because they have the highest prevalence in incidence of prostate cancer. So that's where we want to try and target going forward.
Excellent. And Kerry, you wanted to share some reflections as well.
Thank you, Chair. And I think from a borough-based partnership perspective, I think Neha said we have some very open and honest discussions with each other within the partnership, and I think that's really important. I think we've got very strong understanding what the strengths are in Ealing within the partnership. And it's really important that we punch up in terms of being clear to North West London what the specific requirements are of the Ealing population. North West London ICB cover a range of different communities, and we know that the diversity and the dynamism within the Ealing community needs specialist consideration and specialist response from the ICB. We know that the ICB funding streams for Ealing are different from outer London and inner London boroughs, and we get a worse deal if you're in an outer London borough. And we also know that within Ealing, we're a net importer of some of the most complex needs individuals moving into our care homes. It sounds like I'm making a political pitch here, but I'm setting out the sort of the agenda that we have within the borough-based partnership to ensure that we're fighting for the needs of the communities that we serve in Ealing. And I think we're in a very strong position to do that through the work that we do together. And sometimes it's more challenging for colleagues such as Mark because they cover a number of boroughs, but we're very clear in terms of fighting for the best outcomes for our communities in Ealing in the borough-based partnership. Thank you.
Not a political pitch, just saying it as it is, I think. So, Mark, did you want to share any reflections on the borough-based partnership?
I think it's pretty much been covered, actually. I think, yeah, but it's exactly as colleagues have said.
Excellent. Well, at this stage, then I'll open it up to any questions from colleagues around the room. I mean, I might get us started just in terms of it was really reflecting on the maturity of the partnership. So we've had some reflections, but obviously with the restructure and the redesign, what are the barriers that you see, and how do we shift the dial and take it up a notch? Neha.
So I think one of the big things we've done is using some of our new infrastructure funding that we've received from an inequalities perspective. We've brought in business intelligence capacity, and actually that is a really good specialist support service that's working across all of our partners to use all of the data to make an evidence-based case for anything that we're doing. And if we are doing really well on an area, we've got to shout out about it. If we're not doing so well, we need to be making the case using that evidence to do that. And what we have tried to do with the restructure is, although the team has reduced significantly, and that team is there primarily to support the whole borough-based partnership function and all of the groups that are working and enable all of the back office work to happen, as well as the governance of the partnership. What we have been able to do is reallocate the work streams, really think about all of the meetings that we have and see what we can streamline, see how we can make the pieces of work really connected and how each partner plays their role in each part of the stream. And we think that we will be fine to carry on with the work streams that we've got. What is very evident is we won't be able to do everything in the same way that we've always done, but we're going to do everything we can to try and keep that continuity of the program going so that that's not affected. And I think the other thing is some of our team that have gone into other roles across Northwest London, that means some of the function has also come away from the borough team, which has allowed myself, for example, to really focus in on the work that we've got to do. And it's really important that we continue to keep those really strong working relationships with our colleagues across Northwest London to come in and provide that specialist support to us as and when needed based on the work that we're doing locally.
I just want to finally add that our borough team are coming back to Ealing. So as you know, that we've been temporarily housed in Marylebone, but we are expected to come back to Ealing and Armstrong Way in October.
That's very good to hear. Any other questions from colleagues? So Councillor Raza and then Councillor Conti.
My slight concern is that in the sort of looking at the borough as a whole might then be a little bit unequal in how we deal with certain areas. So I've always found that, or rather my residents in Greenford have found that they have quite a patchy level of where they can access things. And quite a lot of it means they have to travel out quite a bit to get any kind. So it's that kind of geographical inequality, if you like. How are there any ways that we can kind of plug that gap a bit better? Because they really do seem to be struggling a hell of a lot trying to access things, being stuck in the middle of somewhere where at the moment it's like a perpetual work site and has been for the past 4 years thanks to HS2. So a lot of the time what I'm getting back as a councillor is people being stuck on the 92 bus, being unable to make appointments, unable to get to things. And when they have been raising them with their GPs and with people, there's not anything, I mean, it's out of our control. So is there somewhere locally where things can be accessed which don't require so much of the moving around? And is that something that you are thinking about, sort of bringing things closer to people where they are?
Super, and I'll take Councillor Conti as well. Thanks.
It was just on the estates element and in terms of sort of borough-based partnerships and Section 106 money. I know Neha, I've sent you multiple times this year, sort of Section 106 things from Hanger Hill. I think it adds up to almost £1 million. And I guess it's like, how does all that sort of piece together in terms of sort of when, because I guess, you know, often it's piecemeal, like little bits of money at different times. Is there a strategic view to that? And how do you work with the council to ensure that you've got an idea of what's coming down the road in order to be able to make sort of bigger investments, I guess, when you know that, you know, potentially it is £1 million or £2 million that are coming over the course of an 18-month period. I know from an estate's point of view, how does that all link up?
Really good questions, and actually they're very linked, both of those questions, if that's all right. That and that physical estate from which the Greenford area and that Greenwell PCN area can access services, it is very much linked to the estate issue that we've got, and we've been making a case for estate in Ealing for Health for many years, and we've got visibility of all the Section 106 monies. We work really closely with our local authority around understanding where that is and what are the restrictions on how that can be used and where. The pressure comes, which I think I've mentioned in this in previous scrutiny meetings, is when we find an estate to build and working with the developer using the Section 106 monies to kit it out and fit it out fit for health care. what we have found in a number of cases, and it is just getting a bit more difficult, is that the rent that they want to charge as a developer is unaffordable, and it's way above what the district valuer is willing to say that this is worth for Ealing. And I think we all know that the cost of property is rising everywhere, and it affects health as well. So we have been working with our North West London Estates team to develop and keep on developing and reprioritising where we have to focus in on estate where there's so much pressure that we really have to have this happen. And this is across the whole of North West London. So as you can imagine, everybody is saying we need more estate and we need that money for us. And so it's a constant battle. But so yes, any support and evidence that I gather around the needs and the growing population and where we need that health estate is always going to feed into that North West London estates strategy so far. And I don't think it's just our ICB that's affected by this. The funding just hasn't yet made its way through to us. Enough funding hasn't made its way through to us in order to be able to afford that increase in estate. We've got plans in Southall, in lots of development in Southall. We wanted one in North in Greenford. Actually, we were looking at an area in Acton. We've got OPDC on our corner, which is Old Oak Park Development, and that's another pressured area, and Central Ealing as well. So we know exactly where our pressures are. We have small bits of money come from National once a year or once every 2 years on improvement grants for our general practice, for example, where they bid for money, but it's about their practice and see what they can do to improve it slightly with the money that we're giving them. And we've been really successful over the last few years to make the case for as much as possible. And we've been able to support nearly every single case that's come through from our general practices. But it's getting tighter and tighter, and landlords are looking to sell up as well. So I'm not going to sit here and pretend it's not pressure. But our trusts have other sources of capital money as well. So like the CDC work that you've just heard about in West London around all of its estate. So yeah, it's a pressure.
Thank you, that's really helpful. And just on that estates point, actually, so I think JOSC is due to look at the wider North West London estate strategy this year, but we might want to, following that, look at it in the Ealing context. So just to sort of put you on notice about that point. And the other issue that I picked up was that bit around the primary care access. So we're happy to look at that in the November meeting. Councillor Conti.
I guess just on that, it's when on planning committee, when applications come forward, there's always a section somewhere in the report about like different partners, like Thames Water, the NHS, in terms of what their views are. And often the NHS one is like essentially there's no issue with that application or concern. But clearly from what's been said this evening is that there's clearly big gaps. The Section 106 monies often aren't actually being able to deliver the infrastructure that's needed to back those applications. But there isn't ever really a voice from the NHS in the responses that come to applications to actually say, well, no, this isn't adequate or this isn't enough. And I think, if this is the reality on the ground, then actually I think the NHS should be a bit more muscular in their response to these applications to say, actually, this isn't good enough. And, we'll talk about small applications, but, those large applications, I think that's important. I was always just struck. There was one, it was like 3 years ago now, but there was one in Southall. I can't remember, 180, 200 flats. And I think the Section 106 contribution was like £12,000. I remember I brought it up at the meeting, and the NHS comment in there was that essentially that was fine, and that clearly isn't fine, for all those extra people. And I think that, I think there's a bit of a mismatch between the reality and often then what's portrayed on planning applications.
And I think that go on, Councillor Nisa. You are allowed.
I was just interested also in the converse of that, of where you have a state that actually could be freed up for development. And I know that's been discussed at ICB level, is where you have estates that are owned by the NHS that are no longer being used. So it's as much about the under availability of appropriate states in areas that are growing populations, or whether it's under provided, but also those opportunities, hopefully with a new government that's going to be committed to building many more homes that we know we need in our region, is that partnership and that strategic approach to perhaps utilising some NHS areas as well. And that it would be great to get your opinion on that, because it's sort of counterintuitive, but equally I'm sure there are plenty of buildings kicking around that could, or land or whatever that's owned, that could be converted to good use.
Yeah, the problem is some of the what I say, vacant NHS properties, often it requires a significant level of investment to get them to being fit for purpose in terms of delivering frontline services, and again that requires capital, and then it requires recurrent revenue, and that's the constant vicious cycle that we're constantly in terms of constantly waiting for the Department of Social Health and the Treasury to start to think about releasing capital funds to actually build the infrastructure that we require, because we all see right across Ealing the level of new build that's happening. I drive every day and I pass the Hanger Lane, and I can see in the middle of that Hanger Lane we've got that huge development, and I'm thinking to myself, how is the infrastructure around it going to support all those individuals? Schools, health, transport, etc. So, but that really surprises me what you say, Fabio. About these applications and the lack of feedback coming in terms of making it sure it's a strong application, but ensuring all the other parts that will help support that application, I really do understand what they need to do to make it happen. So, yeah.
And I do want to return to that, because I think we could make a recommendation around that point actually. But Neha, and then I've got Councillor Raza as well.
Yeah, and when you look across Northwest London, there is this view, and there is vacant NHS property around Northwest London. The problem is there's not very much in Ealing. So if it's not here, there's not much we can do. So that's the sort of pressure that we've got about the whole of Northwest London that we're trying to do. Quite often with the planning applications, we get odd little ones here without much context at all, saying it's 5 houses or 15 houses and we're going to get this much money. And my message is constantly, I can't do anything with that tiny amount. I have to look at the whole in that area. Can somebody please provide me with that whole in that area so that we can understand the impact? But it's that revenue impact, the ongoing rent reimbursement is the unaffordable bit. Capital has been coming and we've got it there ready to use. It's just that rent is not possible.
Thanks, Neha. Councillor Raza.
I'm going to come off estates and go to primary care. I saw on the news this week that they've been doing some basic sort of men's health in barbershops. And is that something that we'd be looking at locally? Because I think that actually with GP being so busy and their hours being so difficult to actually access, I have actually had several people tell me that they saw it also, and wasn't it such a brilliant idea? Because you get men of all different ages who can get in there, and also for mental health support, it's absolutely looking like a very good idea. So it's something that we'd like to see locally, please.
Great suggestion. I'm sure that will be taken away and considered. That would be fantastic. Did you want to say anything specifically on that?
No, it was specifically on our population health and inequalities work stream. These are exactly the type of the things that we're looking at. So as we get the funding in, it's that Healthy Ealing team that we will be looking to do this type of work. But I know there's another borough in Northwest London that's been looking at that and has done some work. So we can see what learning we can take from there to do something locally. Sounds great. Yeah, absolutely.
Super. I think I'm not seeing any further indications. I will take away an action with Councillor Conti to formulate some wording around how we strengthen that relationship between health and planning, because I've got to be honest, colleagues, at this stage of the day, the recommendation is not rolling off my tongue. I think that's all that is left to say is thank you everyone for your, Councillor Crawford.
That I'm on the OPDC Planning Committee, and there is concern with the Planning Committee. They do have concerns about the infrastructure. So I would like to recommend that you engage with the OPDC and really engage and ask if you could do some presentations. Sometimes there are easy months, easy meetings where you could actually do a presentation. And it's also getting the information from our planners, what's in, and OPDC, what's in the pipeline. So I think its recommendation is looking exactly what you said. It's not, sometimes you hear too late, but the planners know what's coming because they're doing the pre-planning applications where there's no decision, but they are aware of what's going on. Thank you.
Councillor Crawford has successfully formulated the recommendation for me, I think, there, which is really helpful, so thank you. The date of the next meeting is the 5th of November, remember, 9 p.m. is now, 7 p.m. We are covering off the Safeguarding Adults annual reports, the finance position. We've got hopefully the CQC report and also the strategic update on adult social care and public health, plus the same day access piece. So we've got a lot to look at during that meeting. But thank you everyone for your time this evening and have a good evening.
Thank you. Heads of terms on planning applications often